episodes because it's like 187 slides. So that would be a lot of talking. So the objectives of this lecture are, we're going to review the differential diagnosis of chest pain. We're going to discuss the initial evaluation of chest pain. And then we're going to discuss the initial management of life-threatening causes of chest pain. So with regard to differential diagnosis, depending on what you're doing and how the patient is doing, I suggest that you think about differential diagnosis differently. So if you're in the emergency department, or you are seeing a patient who either is or might be potentially unstable, you're going to go about building your differential diagnosis in a different way than, let's say, you're doing internal medicine on the floors with a patient who you know is stable. So if you're in the ED or you're seeing a potentially unstable patient, how do you go about building a differential diagnosis? Yeah, worst first. And if you're doing IM and you're dealing with a patient that you know is stable, how do you build your differential diagnosis? Yeah, so it's just useful to think about that. With stable patients, you really put the most likely first, and then you do include the potentially dangerous things, but you can think about them later. With unstable patients or potentially unstable patients, it's worst first, and you put the most likely ones later. So when you're seeing someone with chest pain, they're potentially unstable. So you want to think about the worst things. And so tell me what the big five are. What are the big five? Okay, so we can fit MI into a little bit of a broader group. Yeah, ACS, so acute coronary syndromes. That's one. What are the other four? PE. Aortic dissection. Okay. We're going to save that for a later slide. Yeah. Tension pneumothorax. Okay, yeah, so pericarditis with pericardial tamponade. So these are the big five. Now, Seth, you mentioned esophageal rupture, which brings me to the big seven, okay? I know that the big five is something that we classically hear about and we're taught to think about. I actually think it's better to think about the big seven, to which you add Boerhaave syndrome, esophageal rupture, and perforated peptic ulcer. Whenever I think about the life-threatening causes of chest pain, that's what I think about. I don't think about five. I think about seven. So I suggest that you memorize this. And these things should be on your differential diagnosis for every patient with chest pain. Now, you may not be very suspicious because they may be telling a story that's very consistent with, let's say, costochondritis. Or maybe they have zoster, okay? But it should cross your mind. And some thought process should happen that makes you think about, is it or is it not one of these big seven? Okay. So, then we can get to the laundry list of all the things that can cause chest pain. And there are quite a few. They range from the bad things to some pretty not bad things like costochondritis or panic disorder. Hey, Erica. Okay. So you should have kind of a list of the comprehensive causes of chest pain, but really, you got to know the big seven. Okay, so how do we do this? We want to rule out the big seven first, and we do this on the basis of taking a history, doing a physical exam, getting some ancillary studies, and then using some clinical decision-making rules where appropriate. And once we rule out the big seven, then we actually want to make a diagnosis. It may be one of those seven, or it may be something else. We want to make a diagnosis and we want to begin treatment. Okay, so we're going to do some scenarios. So you are now the day intern. Congratulations, you have finished the torture of medical school. When you're the day intern, you get a call from the ED at 3:58 p.m., which is unfortunate because your shift ends at 4, but that's the way it is, to admit a patient with chest pain. What do? You're on the phone. You get report.
What else what else is it telling you about this patient? Age, history,
Okay. Yeah, and what are some, so they give you the whole story. They tell you the vitals, the physical exam. What are the fairly key pieces of information that you need to know? Right on the phone. You don't want to get off the phone and go to the ED until you know this. Okay, so some of that stuff.
Age history.
Yeah, all the history stuff. It's great. But what else do you want to know? Yeah, you want to know EKG. You want to know vitals. You want to know troponin. Probably want to know chest x-ray. And you probably want to know if they're currently having pain. So you get verbal report from the ED provider. And if they didn't tell you, you want to know recent set of vitals, EKG, chest x-ray, troponin, and maybe what meds have been started and how the patient responded. So, specifically, are they having chest pain? All right, then you go, and the patient is a 67-year-old male with a significant past medical history of hypertension, hyperlipidemia, type 2 diabetes, coronary artery disease, who presented to the ED with new onset chest pain for 20 minutes. He described the pain as retrosternal, 7 out of 10 in intensity, associated with nausea and diaphoresis. His chest pain resolved as soon as he presented to the ED, and his EKG at that time, without chest pain, was non-ischemic. His initial chest x-ray was unremarkable. Labs were unremarkable, including a normal troponin. As you're evaluating him, his chest pain reoccurs. So there are his vitals. You'll notice he's a little tachycardic, okay? Uncomfortable from active chest pain. He's sweating. His lungs are clear, and the rest of the exam is benign. So are we worried about this guy? Are we not worried about this guy? Okay. So our next steps are, we're going to look at the previous EKG in the chest x-ray, and we're going to order a stat EKG. And what are we looking for on the stat EKG? Okay, so we're looking for changes. One of those potential changes is ST elevation. What else might we see? T-wave inversion. ST depression. Okay. So what EKG changes do we see with infarction? ST elevation. What EKG changes do we see with ischemia? Good. Okay. So that is his second EKG. So first of all, can you even see that from where you're sitting? Not really. Those of you who are towards the front, do you see ST elevation anywhere? Do you see ST depression anywhere? Where do you see ST depression?
5, 6,
1 AVL, V5, and V6. Those are those contiguous leads? Yes, they are. They are the lateral leads. And what coronary artery do they correspond to? The left circumflex. So this person has ischemic changes on the EKG in a vascular territory. So did this story sound like cardiac chest pain? And there are EKG changes. And the troponin was normal. So is this ACS? Yes. And what is this? Unstable angina. First episode of chest pain, never stable angina. For something to be stable, it needs to be unchanging. If you have one data point, it cannot be unchanging. All first-time chest pain is unstable angina. So, good. So there are 4 varieties of ACS: stable, unstable angina, NSTEMI, and STEMI. This is your normal EKG tracing, okay? We already talked about the changes you see in ischemia are different than the changes you see in infarction. In ischemia, you see T-wave changes or ST depression, whereas in infarction, acutely, you see ST elevation, and later you see Q waves. Okay? Now, the T waves can be all kinds of things. Okay? They can be hyperacute. That's usually the first thing you see. Okay? Then they can start to become biphasic. They will invert, and then later they will just be flat. Okay? So you have to be very careful when you read EKGs to make sure that you don't miss hyperacute T waves and blow them off. What else can hyperacute T waves look like or indicate? Hyperkalemia. Yeah, so they're never really great to see them. Okay, this is an example of ST depression. In A, you can see that's ST depression with a biphasic T wave, whereas in B, it's ST depression with an inverted T wave. Okay, now this is ST elevation. What is the isoelectric line that you compare the T segment 2? Let me give you choices. Is it the line between the P wave and the QRS, the PR line, or is it something else? That's right. So it's the T to P segment, okay? So you have to compare this to this, not that. All right, so this is an example of ST elevation on a rhythm strip in V6, okay? Now, this is an example of how important it is for you to use the right isoelectric line. So does this person have ST elevation? I hear like, maybe a little bit. I mean, how much ST? Do they have a full box? No. Okay? It's like maybe a quarter of a box to a half a box. But the problem is that you see the red arrow? That arrow shows you the PR segment. Okay? And if you use that as your isoelectric line, this person has maybe a box and a half, okay, of apparent ST elevation. And that'll throw you off. What this person has is a significant amount of PR depression. So if you use the PR segment as your isoelectric line, A, you're going to miss PR depression, and B, you're going to get confused and think you have ST elevation when you don't. Okay? The other thing is that not all ST elevation is created equal. Okay? You can see the smiley face morphology versus the unhappy face. If you look at the image to the left, you'll see that the bottom one looks a little bit like a tombstone. That's the other way of describing it. So not all ST elevation is the same. This is the ST elevation that you see characteristically with ischemia. This you can see with other things like what? Pericarditis or early repolarization from left ventricular hypertrophy, as an example. Okay? So then the question is, when you do see ST elevation and it does have that characteristic morphology, what's significant? And what you guys should know is, other than V2 and V3, A, it needs to be in contiguous leads. So 2, 3 AVF, those are the what leads? Okay. 1 AVL, V5, and V6 are the V1 through V4 are the, and specifically V1 and V2 are the anterior septal leads. So those are contiguous leads. If you see ST elevation in 1, in 3, and in V6, those are not contiguous leads. Okay? So it needs to be contiguous. Number 2, in any leads other than V2 and V3, if it's more than 1 millimeter, that's significant. If it's in V2 and V3, then you have to play by a different set of rules. Okay? And it's a little more complicated. In women, it has to be more than 1.5. In men, greater than 40, it has to be, it should be more than 2. And in men less than 40, it needs to be more than 2.5 millimeters. And that's because we need to have a lower index of suspicion for women and a higher index of suspicion for younger men. Okay? So I would memorize that because you'll need to know what is significant and what is not significant. Okay. So, and then we get to Q waves, which are the other things you see on ischemic in ischemic heart disease, but this is chronic. These take hours to days to develop. So, you've got this patient, they come in, you see ST depression, okay? What are we going to do? How do we treat this person? What meds do we give? Okay, so we give aspirin. We pretty much give aspirin to everybody unless there's a contraindication. You mentioned oxygen. Yeah, so we used to think that oxygen was like a really good idea and we should give it to everybody, and now we have found that if you give patients oxygen that are not hypoxemic, it actually can worsen their mortality, so only if they need it. I heard beta blocker. Does everybody get a beta blocker?
No, if they're hypotensive.
Oh yeah, so if they're hypotensive, they shouldn't get it. But if their heart rates are pretty low, down in the 60s, they don't necessarily need it. If they're 70, 80, 90, then the recommendation is to beta block them and get them under 60. Some people like it under 50. There are some contraindications to beta blockers other than hypotension. What are they? You're thinking, that's good, that's good. No, you're thinking about anything that will preload reduce somebody, so that's true. What about patients with acute systolic congestive heart failure? Not a good idea. And patients with asthma or COPD that wheeze in response to beta blockers. Not such a great idea. Okay, so you named a couple. You also can throw Plavix at people to kind of double platelet inhibit them, okay? You're going to want to anticoagulate people with unstable angina, or NSTEMI for that matter. And you have some choices. You can use Lovenox or you can use unfractionated heparin. You want to also throw some statin at them. Now, all of these three things, the antiplatelet therapy, the anticoagulant therapy, and the antilipid therapy, those are all designed to stabilize the plaque. And there is data that giving these things early makes a difference, okay? So you should try to do that. Then you want to optimize the myocardial supply-demand curve, okay? And you can do that by controlling the heart rate. You want to use IV beta blockers when you're sort of fine-tuning. You can give small doses of IV metoprolol, like 2.5 or 5 milligrams, and you titrate it quickly down to 60. You have to watch the blood pressure. And after that, you know, you can start giving oral, okay? But you do have to watch out for heart failure. You want to give some supplemental O2. That will help with supply. But again, you don't need to do this unless they're hypoxemic. And then you want to give nitroglycerin. So how does nitroglycerin affect the supply and demand of the heart? How does it do that? That's right. So that decreases myocardial demand. So that is the major way that nitroglycerin works. But the other thing that it does is it increases supply by what? It's a coronary artery vasodilator. Okay, so you're sort of killing two birds with one stone. Now, the dose of sublingual nitroglycerin is 0.4 milligrams. When you start someone on IV nitroglycerin, how do you order it? Is it in milligrams? It's not. What is it in? Per minute. Mm-hmm. And you usually start it at like 5, 10, 15, 30 micrograms per minute. That is a way lower dose than 0.4 milligrams. How many micrograms is 0.4 milligrams? 400. Okay? Now, you take that pill and you stick it under their tongue. How long does it take to get into the circulation? Yeah. So that is a huge dose of nitroglycerin. Sublingual nitroglycerin is a major dose. So if there's someone where you're on the fence with and you want a little more control over how much nitroglycerin they're giving, IV is your friend. Okay? It's much gentler and it's much more titratable. If you give that 400 micrograms of sublingual nitroglycerin, it's in. It ain't leaving. Okay, you're going to bottom that person's pressure and you're going to do a really good job of it. Okay, so if you're worried about hypotension or the way someone's going to react, IV is actually gentler and it's much more titratable. You can start it at 5 mics per minute. Okay, and then you can go up from there if you're worried. Paste has an invariable absorption and is very difficult to predict. So it's not really a great drug for someone presenting with acute coronary syndrome. If somebody has stable angina and you admit them and you want to put paste on them, that's one thing. But it's not really great for acute treatment, certainly not of unstable angina. Okay. And then morphine. Morphine is an analgesic, so it will help with pain control. But how does morphine optimize the supply-demand curve? Yeah, A, it decreases preload, and B, it decreases demand. How does it do that?
Like decreasing anxiety.
Yeah, pretty chills you out pretty good. Okay. So this patient gets aspirin Plavix, Lovenox, nitroglycerin drip, Lipitor, maybe some oxygen, maybe some low pressure, goes to tele, gets a cardiology consult, gets serial cardiac enzymes and EKGs, and then we risk stratify them. Okay? So one of the things to realize is when you're evaluating possible ACS, or any chest pain for that matter, it's more important to rule out badness than to make a differential diagnosis. And ACS is a badness that must be ruled out. So when somebody presents with chest pain and we're considering ACS, what do we do to evaluate whether or not this is ACS? So what are our tools? How do we do that? Okay, so labs, troponin is one tool. What's another tool? Say that again? EKG is another tool. Chest X-ray is another tool. So we're kind of going backwards from. So what do we always start with when we see a patient? Yeah, so we get a history. Then what do we do? Then we do a physical exam. Then we get ancillary studies, chest X-ray, EKG, cardiac biomarkers. And then we use clinical decision-making rules to risk stratify somebody. What is a clinical decision-making rule that we can use to risk stratify people with possible ACS? So heart and TIMI. Okay, we're going to talk about those a little bit later. Okay, so there's this whole thing of, typical versus atypical pain, okay? And a lot of this is actually accurate if you look at the data. Typical, so cardiac chest pain, tends to be vague, described as discomfort or pressure, okay? It tends to last longer than 2 minutes. It doesn't last for days, and it doesn't last for seconds, but it lasts longer than 2 minutes. It is often provoked by activity or exercise. It likes to radiate, especially to the arms, sometimes to the jaw. It doesn't usually change with deep breaths or position. It's often associated with other things like diaphoresis or nausea, and it is often relieved by rest or nitroglycerin, whereas atypical pain is usually not that vague. People will say, it hurts here. If a patient is able to take one finger and point to where it hurts, odds are it's not cardiac. Pain that lasts seconds or days, probably not cardiac. Pain reproduced by movement or palpation, probably not. You have to be careful, but it's probably not. It's more likely to be non-cardiac. Doesn't mean it couldn't be cardiac, because it could, but it's more likely to be non-cardiac. It doesn't usually have associated symptoms, and it doesn't usually change with rest. Now, if you could possibly read this, what you will see is this is likelihood ratios of patients who have a known diagnosis of MI and what the clinical finding was. So who knows? So if a likelihood ratio is greater than 1, what does that tell you? Let's just be simple for a minute. Good. Okay. Yeah. So, and if a likelihood ratio is much greater than 1, they're much more likely to have it. If it's much less than 1, they're much less likely to have it. In general, likelihood ratios that are 5 or more, it's pretty moderately predictive that they don't have it. When you start to get to 10 or more, it's highly predictive, that they do have it. Going in the less than 1 direction, a likelihood ratio of less than 0.5 is moderately predictive that they don't have it. And less than 0.1 is very predictive that they don't have it. So if you look at chest pain radiating to both arms, the likelihood ratio is 7.1. It's pretty high. Okay? If you look at palpation of tender area reproduces chest pain, the likelihood ratio is 0.16. So that's pretty moderately predictive. It's helpful, okay, but it's not super helpful. Now, if you look at the negative likelihood ratio, okay, of palpation of tender area reproduces chest pain, it's 1.2. And so this is where you have to be a little bit careful. So seeing reproducible chest pain, okay, does make it less likely, but it's not tremendous, okay? If you look at that negative likelihood ratio, it's 1.2. We like to see 10 would be like awesome, okay? So it's not fantastic. Here's another chart, okay? And you'll see on the right the positive likelihood ratio. So radiation to right arm or shoulder, 4.7. Both arms or shoulders, 4.1. The old teaching of left arm, not quite so true, okay? Both arms, right arm, more likely, but still, those likelihood ratios are not huge. They're in the 4s. Okay. If you go down to described as pleuritic, so it's 0.2. And if you go down to reproducible with palpation here, it's 0.3. Okay? So remember, 0.5 or higher is moderately predictive, and 0.5 or less, and 0.1 or less is very predictive. So this is not it's not super helpful. It is certainly less likely to be cardiac if it's reproducible, but don't hang your hat on that, which is what a lot of people do. Now, we get to this fun study called the GRACE study, which looked at painless acute coronary syndromes, okay? And what it showed is that 8.4% of patients with ACS presented without chest pain. 24 of those patients were not really recognized initially, so that's not fun. So what did they have? 50% of them were short of breath. A quarter of them were sweaty. Another quarter of them had nausea and vomiting. Some of them had syncope, okay? This loss of consciousness would be syncope. If you're having syncope from loss of consciousness from ACS, it's syncope. So who gets this? The elderly, females, and diabetics. So in the elderly and females and diabetics, beware. They may not come in with chest pain. Almost 10% of them didn't. Okay. So what do we take from all this? From those likelihood ratios and from the GRACE study? What we take is that no single element of the chest pain history is powerful enough to allow the clinician to make decisions according to it alone. It's not good enough. It's helpful, but alone it's not good enough. Okay? So what about risk factors? Here are risk factors. Notice I have obesity in parentheses. The reason why I have obesity in parentheses is depending on which clinical decision-making rule for risk stratification you use, it may or may not consider obesity to be important, while it is a risk factor. So how good are risk factors? Okay. Oh, here are some underappreciated ones, by the way, like lupus, rheumatoid arthritis. Those are risk factors. Anybody with known hypercoagulability, anybody using cocaine, and Asian heritage. Cocaine. Why is cocaine a risk factor? What does it do?
Causes vasospasm.
Does it do? Yes, it does. Does it do anything else?
Causes plaque buildup.
Chronically, it does, and acutely, it can precipitate platelet aggregation. Okay, so A, you're vasospasming, and B, your platelets want to aggregate. Bad combination. Okay, so how helpful are risk factors? There was a study done. Do risk factors for chronic coronary blah, blah, blah help diagnose acute MI? Okay, they looked at 804 patients. It was prospective. All patients had 3 sets of troponins drawn 12 hours apart. That is the graph. What does this graph tell you about how helpful risk factors are? Is this a happy graph? This graph sucks. Why does this graph suck?
Because it doesn't follow a trend.
Right. What's particularly disturbing about this graph?
It's not in color.
Yeah, that is. It's terrible that it isn't in color. How do you feel about that 0 risk factor? Yeah. If you had no risk factors, you were pretty equivalently at risk for if you had 3. I mean, it's much better to have 3 risk factors than 2 risk factors. I mean, the worst is having 1 risk factor. So if you smoke, you should quickly develop hyperlipidemia and a family history. Okay? Because if you have 3 risk factors, you're better off. Yeah. So this is a very troubling graph because it doesn't follow a trend. Okay? But particularly, having 0 risk factors was still not really as protective as what we might imagine. So risk factors don't reliably predict the risk of an acute event. So history's not that helpful. Physical exam, we know, isn't that helpful. All right, so the EKG. How helpful is the EKG? Well, it's important. You got to be good at it. But it's only diagnostic in 1/4 to half, which means, by applying advanced mathematical models, that means that it's non-diagnostic in 1/2 to 75%. Okay? It can be totally normal in 10 to 13%. And if patients come in and they're not having symptoms, it's kind of hard to tell how helpful the EKG is. Remember, unstable angina is transient. if the patient walks in and they're having chest pain right in front of you and you do an EKG, that's one thing. But if they're not, and the chest pain was 10 minutes ago, that EKG is probably not going to be that helpful. So you got to get serial EKGs because the sensitivity of a single EKG isn't that great. So EKG, not that helpful. So history not great, physical not great, EKG not great. Biomarkers. What do we think about biomarkers? Yeah. They're an important tool. They're a marker of myocyte necrosis. However, they are not a marker of myocardial ischemia, which means, does a troponin help you in any way, shape, or form to rule out unstable angina or stable angina? It does not. So it's limited, okay? Furthermore, if a patient walks in and has an NSTEMI right in front of you, right that very minute, and then drops dead and codes, and you draw a troponin, will it be helpful? Why not? Because it takes, I heard mumbles. Well, yeah, I mean, it takes like 4 hours, okay? And you can also get some false positives, you should know, from an elevated creatinine. And there are situations where there will be a very low level of myocardial necrosis, but it's not because there's a thrombus in an artery. It's because the demand of that muscle, that myocyte, or many of them, was much greater than the supply. And so you can have a situation where, let's say, a 90-year-old with pretty bad LVEF is in septic shock, super tachycardic from pneumonia, and is hypoxemic and anemic. This is a setup for huge amount of demand without a lot of supply. And they may not have a thrombus in an artery, but they could have a positive troponin from what we call demand-related ischemia, especially if they have an elevated creatinine and they're not able to clear it. So you can have some false positives, okay? So if all of these things have their limitations, then when we see patients with ACS, we have to come up with some kind of tool that can stick them all together and allow us to risk stratify them, okay? So when I asked you guys, you did mention the heart score. There's also the Gray score, and there's also the TIMI score. So we're going to start with heart. It's a prospectively studied scoring system, and what it's designed to do is to tell you who's going to have a MACE within the next 6 weeks and who will not. What is MACE?
Major adverse cardiac event.
Yeah, yep, that's exactly what it is. Major adverse cardiac event. Defined as all-cause mortality, so if you die, okay, if you have an infarct or you get revascularized. And what we found is when you add up the score, and we'll get to that in a minute, patients with a score of 0 to 3 have less than a 1% risk of MACE at 6 weeks. That's pretty low risk. It's actually 0.99, okay? Negative predictive value of 96%. That's pretty good, okay? Now, all other scores are moderate to high risk, and they need further evaluation, okay? The higher the score, the more the risk. Now, this is the key thing here. While the heart is sometimes compared to TIMI and GRACE, okay, TIMI and GRACE measure risk of death in patients with established ACS. They don't perform well at telling who has ACS in the first place. That's not what they were designed to do. They're designed to say, my patient's got ACS. How bad are they going to do? TIMI is designed to go, I don't know if my patient's got ACS. How bad are they going to do? So these are kind of two different things, okay? So what are the components of the heart score? I'll give you a hint. The letters correspond to the components. First one is history. What's E? What's A? Okay. What's R? And what's T? Okay. So you get a score of 0 to 2 in each of these things. 0 is slightly suspicious. 1 is moderately suspicious. 2 is highly suspicious. Okay. So for history, if you don't think it's ACS, it's a 0. If it's moderate, it's 1. If it's highly, it's 2. It's important to note that this portion of the heart score is entirely subjective. Okay? And this is because clinicians are not stupid. Okay? despite the limitations of the history and the physical and the EKG, we do get pretty good at being able to put all those things together and form a clinical gestalt. And so this is the portion of the heart score that includes clinical gestalt. Then there's the EKG, okay? If you have ST changes, you get 2 points. If it's not normal, but you get 1, but there aren't ST changes, you get 1 point. If it's totally normal, you get 0, okay? Age, less than 45, 0, 45 to 65, 1, greater than 65, 2. Risk factors, okay? If you have none, you get 0. If you have 1 or 2, you get a score of 1. If you get 3 or more, you get a score of 2. Obesity counts, okay? Doesn't count on TIMI. Counts on heart. Troponin. If it's really high, like more than 3 times the level of normal, you get 2 points. If it's elevated, but less than 3 times, you get 1. And if it's normal, you get 0. Now, here's the time to troponin positivity. The blue arrow points to the time where the non-highly sensitive but modern troponin assays will start to be positive, and that's really at 4 hours. There are highly sensitive troponins, but there's a lot of false positives, and we don't quite know what to do with them yet. So we're not using them at this hospital, and at most hospitals, they're just still being studied. So this is a validation of the heart score, and it shows you the % chance of MACE. So for a low risk, so 0 to 3, it's less than 1%. When you get into the 4 to 6 range, it goes up to 11.6. And when you get to 7 to 10, it goes way up. This is a very useful scoring system, okay? So why heart? The history is really helpful, okay? The H, the E, the A, and the R, if you put them all together, they have a very, very high sensitivity, but they're not that specific. If you lump them in with troponin, you pick up the specificity from the troponin, and you get a score that's both sensitive and specific. So it's pretty good, okay? GRACE and TIMI, they were designed to look at how bad people with ACS are going to do if they get this or that. So it's useful to know what TIMI is, which I have here, okay? And to be able to score people on TIMI. But TIMI should be used differently. Heart should be used to help you figure out how at risk for a MACE somebody is, okay, at all, okay? So do they have ACS? Whereas TIMI is, you already think they have ACS. How should I manage them? Should I be aggressive or should I not be? Okay, moving on. Case 2, you're the night float intern. At 9 p.m., you're called by a tele-nurse because the patient has developed chest pain. Miss Z is a 62-year-old female with a significant past medical history of hypertension, hyperlipidemia, coronary heart disease, COPD, and a right total hip replacement 3 weeks ago, who was admitted 2 days ago for a COPD exacerbation. What would you do next? On the phone. What do you say? What do you want? You want vitals. What else do you want? You want, get me an EKG. Okay. So you want the most recent vitals, you want to get a new set of vitals, you want to get a stat EKG, you want to have the old EKG waiting for you. You could certainly ask for a chest x-ray, and you want to go see the patient. So you go see the patient, you're at the bedside, and you want to, this is the thing you do. Is the patient stable or are they unstable? If they're unstable, you call a rapid response. Okay? Wherever you work, the chances of them having a rapid response team is very high. If they're stable, you continue with the evaluation. Okay? Then you're going to start thinking about differential diagnosis, and you're going to think about your worst first, and you're going to have your big 7 in mind, and you're going to evaluate the patient by taking a history, doing an exam, getting ancillary studies, and using clinical decision-making rules. Now, as you're going through this, if you think you have a big 7, you've got to escalate that. You definitely want to notify your supervising resident. So if you have an R3 or an R2 that's working with you, they need to know. Okay? Otherwise, you're going to notify your attending if you're working directly with them. Okay? If not, you're going to keep going, and you're going to want to write an encounter note that details the reason you're called and has a SOAP section. Okay? So you go see this patient. She had been getting better on nebs and steroids, but suddenly developed chest pain that's left-sided, 8 out of 10 and worse with breathing, and it doesn't feel like her MI. She's tachycardic, she's tachypnic, she's hypoxic on 2 liters, and that's new. She's in distress. She's wheezing bilaterally. She's tachycardic, there's a loud S2, there's some JVP, the chest pain's not reproducible, and the left lower extremity is edematous with calf tenderness. Is a big 7 on the list? Okay, what are you worried about? Okay, so great. Your next steps are you grab an EKG. Is this EKG potentially consistent with pulmonary embolism? Don't you dare do the 300, 150, 100, 75, 60, 50 rule. Count the QRSs and multiply by 6. Is this person tachycardic? Yes. What is the most common EKG finding in PE? Sinus tach. All right. Is this a right bundle branch block? Well, the QRS is a little wide in V1 and V2, and it's rabbit-eared. So yeah, kind of looks like it. And how about, is there anything else interesting here? Like S1, Q3, T3. Very good. Okay. That's the chest X-ray. Most chest X-rays in PE have some abnormality. There are a lot of them, but it's definitely not diagnostic. So you think it's PE? Great. How good is the history? Well, 73% have dyspnea at rest, 44% have chest pain, 44% have calf or thigh pain. There are usually symptoms, okay? How good is the physical exam? Well, often, but not always, people are tachycardic and tachypnic, okay? If you see this classic triad, you should have a very high index of suspicion. How do we work PE up? We've talked about this ad nauseum. It's entirely dependent on risk stratification. The tools you use for risk stratification are always dual. You use your clinical gestalt, and you want to use a clinical decision-making rule, such as a Wells. That's the Wells score. You get certain points for certain things, okay? In a hospital that has a D-dimer assay that is negative at less than 235, you cannot use modified. You have to use the Wells, and they are low risk if they are less than 2, so a score of 0 or 1, okay? And then you can look at this chart, and if you are risk stratifying somebody as very low risk, you can use PERC, okay, which has a really high negative predictive value in that population. If they're low risk, not very low, but low, you can use D-dimer, and that also has a very high negative predictive value in that population. If they're moderate risk, you got to CT or VQ them. CT is usually preferred. And if they're high risk, you definitely need to do CT, but it's probably not good enough because the negative predictive value of a negative CT in a high-risk patient is only 60. So you have to pair the CT with something else. Could be VQ, could be ultrasound, depending on how high risk you think they are. This is PERC. It's very useful because it depends on demographics and vitals. There are no labs involved. So in a very low-risk patient, a negative PERC has a negative predictive value of 98%. It's fantastic. It's just as good as D-dimer. And it's no labs. Okay? Now remember, with PERC, you have to have a low clinical gestalt, and you have to have none of that stuff. Okay? That's an example of a chest CT showing a saddle embolus. This is the PE. Right here. Here's another little filling defect. Okay? How do you manage PE? It depends if it's massive or submassive. What's the definition of massive PE? Yes. Okay? So massive PE is a systolic less than 90 or a drop in the patient's systolic of 40 or more from their baseline, and that has to last for more than 15 minutes. So let's start with submassive PE. You want to anticoagulate them. You have some choices, but Lovenox is the preferred choice because there's less treatment failure and there's less bleeding. Okay? Then you need to bridge them to something chronically. Now you can use warfarin. You can also use a NOAC. All 3 NOACs are now approved for chronic maintenance treatment. Okay? Just so you know, if you're really suspicious, you can anticoagulate somebody before you make a definitive diagnosis. I would document that there are no contraindications to anticoagulation, but then you can pull the trigger. Now, if they have a massive PE, You want to hemodynamically stabilize them. You want to volume resuscitate them. But one of the key things here is you don't want to over-volume resuscitate them. You want to restore euvolemia. If they're hypovolemic, make them euvolemic. But once they're euvolemic, giving them more fluid is not going to help. So giving 8 liters of fluid to a hypotensive patient with a PE who's euvolemic will not help them. They need pressors. Make them euvolemic and then put them on a vasopressor. They may need respiratory support, whether it comes in the flavor of nasal O2 or positive pressure ventilation, whether non-invasive or invasive, depends on the patient. You want to empirically anticoagulate them if you think they have a massive PE while you're awaiting definitive diagnosis, and then you thrombolyse them. Okay? Alteplase, 100 milligrams over 2 hours, okay, is the typical dose. If, for some reason, you cannot give thrombolytics, like they have an absolute contraindication to it, you can try to use catheter-based thrombectomy or embolectomy, okay? This is an IR thing. You can also call your CT surgeon and put this person in the OR and put them on bypass and open their chest, and you can actually do an operative thrombectomy, okay? So that's PE in a very brief nutshell. Moving on. Case 3. You're called to the ED to admit a 65-year-old male with chest pain. Mr. Q is 55. History of hypertension, hyperlipidemia, coronary artery disease, type 2 diabetes. Comes to the ED with 2 hours of retrosternal chest pain. His pain is different from his MI and is very bad. It radiates to his neck. It began suddenly 2 hours ago and initially subsided right after he was placed on a nitroglycerin drip. But now it's starting to radiate to his left arm and back rather than to his neck. Is a big 7 on your list? What is the big 7 you're worried about? Dissection. Okay. So he's tachycardic, he's hypertensive, he's in discomfort, he has JVP, he has diminished left-sided pulses. His extremities are cool, and he has a blood pressure differential. We still thinking dissection? Yes, we are. Okay. That's the chest X-ray. What do you think? He does have a widened mediastinum. Now, there is one thing going on with this chest X-ray that makes the mediastinum a little bit difficult to interpret. And what is that?
It's a AP versus PA.
That's right. Okay, so it's an AP film which does change the cardiomediastinal silhouette and makes it look a little fatter. And it's rotated, which always enlarges the cardiomediastinal silhouette. That being said, this looks wide. Okay, so what do you do next? It's a big 7, okay? So you're going to get your R2, R3, or attending involved. You're going to complete the workup, and you're going to begin initial treatment. So aortic dissection is a problem, okay, because it's rare. We actually don't see it a lot. I have seen 2 cases of aortic dissection in the last 3 years, okay? It's rare. The symptoms also can mimic other things, and it likes to kill you, okay? So this is a bad combination. We don't see it a lot. It likes to fool us, and when we have it, it's bad, okay? The mortality is 50% at 48 hours. It basically goes up by 1% per hour after the dissection starts. So you don't want to get to 100 hours, I guess, okay? How does this work? Well, the aorta is exposed to high shearing pressures. Eventually what happens is the blood wears down the inner layer and dissects between the intima and the media. It will then go propagate for however long it wants to, and then sometimes it will pop back in, so you have a true and a false lumen. Okay, now why is this bad? How does this cause trouble?
It can travel back to the pericardium, cause tamponade.
So yes, it can travel back into the pericardium and leak into the pericardium and cause tamponade. What else can it do? Yeah, it can rupture. That's bad. Okay, when your aorta is like spurting blood, that's bad. What else can it do? So it can dissect and occlude an artery. So it can occlude a coronary artery. but it can also occlude a renal artery, a celiac artery, okay? So it's trouble. Okay, most dissections begin in one of three places. About 2.2 centimeters above the aortic root, okay? So there in the kind of in that specific area or anywhere else in the arch, and also distal to the left subclavian. But 90% of them occur in the first 10 centimeters of the aorta. Most dissections are thoracic, okay? Now this is the classification scheme. I find it most clinically useful for me, because I do EM and IM, to think Stanford, okay? Because the treatment for type A and type B are very different. If you're a vascular surgeon, okay, you will think about it in terms of DeBakey, type 1, type 2, and type 3, because it really bears on your surgical approach. But to be simple, if it involves the ascending aorta, it's a Stanford A. If it involves the descending aorta, it's Stanford B, okay? So here's how it kills you. Either it's going to cause tamponade and rupture into the pericardium, it'll take out your aortic valve, okay, or it'll rupture. The way that it can cause morbidity is a branched vessel occlusion. So of the coronaries, the carotids, the spinals, the mesenteric and celiac, or the renal arteries, okay? So it's bad one way or another. There are lots of risk factors. The top line lists the common cardiovascular risk factors, but there are other things that you need to be aware of, like cocaine, pregnancy, and syphilis, for example, okay? You have to be very suspicious when your patients come in, if they're young and they're on cocaine, or they're pregnant, or they have risk factors for syphilis, if they're presenting in a way that's potentially consistent with dissection. If they're pregnant and doing cocaine and have syphilis, I'd be very suspicious. Okay, so how good is the history? Well, if you look retrospectively, 96% of patients with known dissection have at least one of these three things. Abrupt onset of thoracic or abdominal pain that's sharp tearing or ripping, mediastinal widening of the chest x-ray, or a variation in their blood pressure. Okay, more than 20. So 96% of them will have at least one. So be familiar with those things. 90% of them will have severe pain, okay? And most of the time that's abrupt. It's often described as tearing or ripping, and it can migrate, but only about a fifth of the people will have migrating pain. Hypertension, okay? So this is interesting. Not everybody is hypertensive. And those people who are hypertensive, a lot of them are not necessarily very hypertensive. And you can see there's a big difference between the type A's and the type B's. The take-home point here is don't think that you've ruled out aortic dissection because they're not hypertensive or not severely hypertensive. Similarly, 20% of people will manage to have a dissection without a blood pressure differential. Okay? Pulse sensitivity, pulse differential, not that sensitive. Test it anyway. Because if you feel it, it's significant, but it's not that sensitive. Okay. You should look for focal neurological deficits. Remember, this can take out the spinal arteries. Okay? And you should listen for a murmur. Okay? Because people can have them. Ancillary studies, EKG, not all that helpful. Most of the people who have changes, it'll be very nonspecific. Okay? Chest x-ray will be widened in 62% of people. 50% will have a change in the contour of the aorta, not necessarily the whole mediastinum. Okay? D-dimer, by the way, has a decent negative predictive value in patients that you think are low risk. But the problem with this is we don't have really good risk stratification tools to help you decide who is low risk, and we don't have a fantastic idea exactly how good the negative predictive value is. This is an example of a chest x-ray where you see both the change in the contour of the aorta in 2, and you see the widened mediastinum in the measurement marked 1. So how do you work this up? They need CT angiography, if possible. Okay? It's pretty darn sensitive and specific. If the patient has an elevated creatinine and we think they have dissection, we will often do the CAT scan anyway, because the risk of misdiagnosing or delaying diagnosis is much greater than the risk of contrast-induced nephropathy in most patients. Now, if the creatinine's 4 or 3, that's a little different than if it's 2, and you think it's because they're volume deplete. Alternatives. You can do TEE, okay? But TEE is not available in many community hospitals. You certainly can't get it here after hours. And even during hours, these are unstable patients, and to get TEE, they're going to need procedural sedation, intubation. It's kind of a big deal. It takes a while, whereas the CT is very rapid. Furthermore, you can't really see the descending aorta that well, and it's hard for you to tell where the dissection goes, what vessels it affects, and so a surgeon will want to see a CT almost always, even if the TEE is positive. MRI, not a good idea to take the long road trip and lay on the table for hours in your patient who you think has a dissection. So it's really only useful for surveillance. Picture on the left is the intimal flap in a CT with IV contrast. In case I didn't mention it, to see PE and to see dissection, you really need IV contrast. A good radiologist might be able to see some subtle evidence of dissection without IV contrast, but it's not very sensitive. So you need IV contrast, and you cannot see PE without IV contrast. And on the right is the ultrasound, and you can see the true and the false lumen there and the intimal flap. Okay? For bonus points, what's this? I'll give you a hint. It's not the superior vena cava vertebral body. Okay, so how do you manage this? Type B dissections don't go to the OR unless they have end organ damage from a branched artery occlusion or they don't respond to medical therapy. So basically you want to control their blood pressure. You want to get it down to a systolic of about 110 to 120, and you want to get their heart rate down too. It doesn't help for these patients to be very tachycardic because every beat exposes the aorta to more shearing forces. Beta blockers that you can give IV and titrate are your first line, so esmolol and labetalol. You can use nitroprusside, however, it really needs to be paired with a beta blocker, otherwise you can get a reflex tachycardia. And hydralazine is a problem, because you will get a reflex tachycardia, and also it's not titratable. You can't put somebody on a hydralazine drip. You can put someone on a nitroprusside drip and be able to very accurately titrate that blood pressure, but hydralazine, you got to push dose it, push. You can overshoot, and it's not easy. Once it's in, it's in. You don't want to drop these people too fast. So hydralazine's kind of out. You want to watch for hypotension, and if they are hypotensive, fluid resuscitate them and make sure that they don't have a complication like a tamponade, an MI, or a rupture. Okay? The in-hospital mortality for type B is 12%. If you look at type A, the in-hospital mortality is more than twice that. And remember, it goes up by 1% per hour. So with these guys, they need to go to the OR. They need to go to the OR immediately. The longer they take to go to the OR, the worse they will do. You can control their blood pressure in the meantime, but basically you start the labetalol and you call the CT surgeon. All right, so we are not going to do episode 2 because that was a lot. So we reviewed the big 7. What are they? ACS, PE, dissection, pericarditis with tamponade, tension pneumothorax. And the other 2, esophageal rupture and peptic ulcer disease that perforates. Okay. Any questions about ACS, PE, and dissection? All right, well, next week we'll do, the other big ones. Have a good afternoon.
Yeah.